Kia ora, my name is Margie Olds, and this is a story on recurrent shoulder instability. The basics for this presentation is a presentation I gave at the Shoulder and Elbow Congress in Rotterdam in the Netherlands in 2025. It's a story that I bring you from across the globe, specifically from Auckland, New Zealand. Once upon a time, in a land far, far away, lived a shoulder therapist who treated lots of patients with shoulder instability. She worked hard to deliver the best non-operative care that she could and would discharge her patients after a period of rehabilitation with excellent range of movement and strength and proprioception in the best way she knew how. And even though she loved her job, still the therapist was sad and frustrated, because sometimes, even though her patients had been discharged with excellent results, they would turn back up at her door with a re-injured shoulder with another episode of shoulder instability. We call it recurrent shoulder instability. She knew that in some far-off lands there were some surgeons who would operate on all the first-time traumatic anterior shoulder dislocators that presented in the clinic. But she knew this wasn't helpful in her land because many of the patients she treated did well after a period of non-operative management and having rehabilitation. She also knew the concept of number needed to treat, which tells us the number of patients that are needed to be treated to save one person from further recurrent shoulder instability. And based on the evidence, depending on the paper that you would read, at worst this would mean 7 people had surgery to save one person from shoulder instability again. And more recently, the number needed to treat has been shown to be 12. So that tells us we need to operate on 12 people so that one person will not have recurrent instability. That is, 11 people will be operated on and they didn't need the surgery anyway. To give this story some context, the story happens in a land far, far away called New Zealand, where many of the people play contact and collision sports. Shoulder instability occurs not infrequently, and the culture is one where the people hail from pioneers and adventurers. They are a pragmatic people with a strong sense of family and fun, where physical activity and enjoyment of the outdoors and sporting activities make up the culture. Alongside this culture, in this far, far away land, there is a government scheme which provides compensation for traumatic injuries that occur during sports and work. It provides heavily subsidised access to healthcare and compensates for time off work. All traumatic injuries are registered with this scheme so that the people in this far-off land can receive entitlements. In short, it is the perfect environment to study traumatic shoulder instability. And so the therapist started her PhD at the university. The premise for this work was that there would be a population of people with a first-time traumatic anterior shoulder dislocation, the large round circle. Of those, there will be a group of people who will only have one shoulder dislocation and a group of people who go on to have multiple episodes of instability. We wanted to know which group people would be in after the first dislocation. And so the PhD was set about like this, that involved a meta-analysis, which means looking all the way through the literature to find out all the risk factors that might mean people were going to have another dislocation. We published this meta-analysis first in adults in 2015 and then in children because we know that children present with different risk factors. So we took these risk factors and went forward then into a prospective cohort study where we followed these people over time to see who would have another dislocation. People most want to know about recurrent instability, and so this is our recurrent instability at the different age of the participant when they had their shoulder dislocation. You see recurrence is in grey and non-recurrence is in black. And similar to other research, we found that people aged 16 to 25 had around 50% risk of recurrent instability. And if they were aged over than 25, then their risk of having another episode of recurrent instability decreased. We also found other factors that predicted whether people were going to have another shoulder dislocation, whether they had a bony Bankart lesion where the bone is chipped away from the socket, whether they wore a sling, and having your arm in a sling after a dislocation will decrease your risk of having another episode of shoulder instability. We measured their scales on pain and disability, we measured their shoulder activity, we measured their fear of re-injury, and we measured their shoulder-related quality of life. We also saw a relationship between having a dislocation in your non-dominant side, which would decrease your risk of dislocation, having an ethnicity other than New Zealand, European, Maori or Pacifica, age 16 to 25, and involved in contact sport, all trended towards significance. And so we put these variables into a multivariate predictive tool where we could then establish whether the people would have recurrent instability or not. And this is our calculation tool. You can predict recurrent instability, whether a person is age 16 to 25, whether they have a bony Bankart lesion, whether the lesion is on their dominant side. You see that immobilization is protective, and that's why the tool has a negative number. And then the Spady total and the TSK, which measures your fear of re-injury. And you can use this tool here on my website, margieolds.com/PRIS, P-R-I-S, and enter your data there on the tool. So you click the bottom there for age, whether it was immobilized or not, your previous dislocation, and if you had a bony Bankart lesion, and you can download those questionnaires and enter the number into the website, and it will tell you if you are at high or low risk. So in conclusion, tools are available to predict recurrent shoulder instability after a first-time traumatic anterior shoulder dislocation. You can increase the clinical utility of this tool by using the online version that I just showed you. Be aware that it has limited sensitivity, and I think further research needs to look at other labral lesions or a clinical apprehension test, or measure other psychosocial variables, and that's really the topic of our future research. But we know that non-operative management is a good alternative for patients after a first-time traumatic anterior shoulder dislocation. We know that there are both physical factors and psychological factors that need addressing. Typically, the physical factors look like regaining strength in positions at the speed you need that match the demands with which you need to use your shoulder. We also know that getting the movement back in your shoulder is important. With regards to the psychological factors, we're learning such a lot about the psychological factors that are involved after a shoulder dislocation. We know that addressing fear and improving confidence in your shoulder is really important in non-operative management. And so ideally, non-operative management looks like addressing all these factors after a shoulder dislocation. We think you need a period of immobilization that varies between 1 and 3 weeks, and that is patient dependent. You need to gradually improve your range of movement, and you need to work in a safe zone initially that's specific for your type of instability. You need to address other deficits in your legs and trunk that help support your shoulder. You need to address the psychosocial impact of having a shoulder dislocation, and then look really for the strengthening. We know that strength that needs to be load and task sufficient so that you have enough speed and enough volume to be able to maintain what you do. And some ideas for your regaining your rotator cuff look like trying to get better strength in the front of your cuff, that anterior rotator cuff. Some exercises to try to improve your posterior cuff. And you need to be aware that these are also patient specific, and really none of these exercises should be painful. You need to address any deficits in your scapula, and these are some ideas for both your lower and middle trapezius as well as serratus anterior. And so if you're a patient who's had a shoulder dislocation, I've made an ebook for you to help you really understand and step through this process. You can click there on the QR code for the book. And if you're a therapist who wants to know more about non-operative management for shoulder instability and want to help your patients who have had a shoulder dislocation, then there's an online course here that you can click also on this QR code. So thanks very much for your attention. Please be aware that this presentation is for educational purposes only and is not intended to provide medical advice, diagnosis, or treatment. This information should not be used as a substitute for professional medical evaluation, and you do need to access care from your orthopedic surgeon or your physical therapist if you need specific medical advice.